Hello, everyone. I am Dr. Shree. I'm a plastic surgeon chairing the Department of Plastic Surgery at Chandan Hospital, Lucknow. And with me is Dr. P. Umar Farooq Baba, sir. Sir is a board certified plastic surgeon working as an additional professor at Sher Kashmir Institute of Medical Sciences, Srinagar. He's associate editor of PRS Global Open, assistant editor of the Journal of Medical Sciences, editorial board member of various national and international journals, reviewer of reputed national and international journals, 65 publications to his name, and he's an executive member of APSI and ISSH. He's a joint secretary of Nabi and member of the research and academic wing of ISSH. So,
Thank you, Dr. Harsh, for this nice introduction.
we will be talking on the update on the management of burns in pediatrics. And it is a published article in the British Journal of Anesthesia written by Dr. A. Suman and J. Owen from the Royal Manchester Children's Hospital, Manchester, UK. So, by the end of this article, we should be able to deal with the initial management of a child presenting with burn, the importance of accurate estimation of burns as total body surface area and subsequent fluid resuscitation, the anesthetic management of a child with severe burns. Burn injuries in children in British in Britain, about 6,600 of the burn cases, which constitute about 17.5% of all trauma cases, are admitted for burn management. And the majority of the admission result from scalds, followed by contact burns, flame burn, electrical, chemical, and radiation burn. So I would like to ask you, sir, what is the annual admission rate at your center? And is scald burn the number one cause of the burn at your center as well?
As our center is concerned, I can say almost about half, 45 to 48% of our burn admissions are pediatric, less than 15 years of the age. And most of these burns are the number one, the scalds, which constitute about 60 to 70%. These are followed by other burns, mainly the burns caused by the electrical burns, followed by the burns by the contact for we have a pot, heating pot, that Kangri burn. These are a good number of the patients come with the Kangri burns, especially of the hands in children, and rest of the contact burns, flame burns, and others. So main is the scald, as is the trend in other parts of the world.
Burn injuries in children, uh, see, they are more susceptible because of the thinner skin, and the babies are vulnerable because they are not able to move away from the causative agent. The toddlers reach up for cups and tables that can contain hot drinks. Impact of burn injuries in a child. Most pediatric burns are small and can be managed without a specialist center. The thermal injury to the skin compromises its protective functions, and the effective barrier is lost, resulting in hypothermia and infection. So, sir, I would like to know what would you suggest for prevention of hypothermia and how do you manage it?
Actually, hypothermia in children is a very grave problem. So at the start of the burn, we should prevent hypothermia. No doubt we have to cool the burns, especially we are taught that the burns should be cooled with the water. Tap water, preferably not the cold, ice cold water. So after the cooling of the burn in a patient, in a child, so patient is to be then kept warm. It can be done by using some warm clothes like the towels or the blankets can be used to wrap the child in that. And in my opinion, best is that the child remains in the lap of the mother so that she can cuddle her in her lap so that the warmth is given to the child. And whenever we give the fluids to such a child, we should use the warm fluid. And the ambience where the child is, it should be warm. Maybe use the radiators or the rooms are centrally heated. As our part is a colder place, we have these arrangements here to keep the child warm.
The role of anesthetist. Anesthetist plays a crucial role in the initial resuscitation, perioperative care, and procedural sedation and pain management. The initial management stages of seriously burned children include an airway assessment and management, intravenous access, sedation, analgesia, and transfer. The initial management of all the ABCDE, the airway, breathing, circulation, disability, and exposure, is similar to as other trauma patients. And vigilance is required to see for other injuries in these burn patients. Assessment of the size and depth of the burn is of paramount importance. We all know the types and categories of burns. So there are many applications which are available. One is the Mercy app, which helps in assessing the percentage of the burn, fluid resuscitation calculations as well. So you can open the app, and on opening it will reveal the Lon Browder chart. You have to tap and rotate to view the side of the body, and burn present on the patient. You have to draw on the chart the burn area which is present on the patient, and the total body surface area value will reflect in the bottom right corner. The other charts which we have been familiar with are the London Broader chart and the rule of nines for adults and children. So, sir, I would like to know which of these do you use in your clinical practice?
In our clinical practice, mostly we use the London Browder chart because it gives, yes, in children as well as in the adults, because it gives the more accurate estimation of the burn percentage. And in some children, we may use the modified form of rule of nine, but really we don't use much. In fact, if the children are having the burns, scattered burns, or like in adults also, we use the palm more frequently than the rule of nine now. And London Browder chart is the universal. We are using that. And regarding the Mercy app, we are not using. Actually, it is not coming up in our phones here in India. Previously, it was coming. Now we are using our own Burnade app, which is a very easy app. It is on all our phones. The method is the same. That you have to enter the details of the patient, then you have to mark the areas of the burn, and it gives you the estimation of the percentage of the burn. And also, when you enter the age, also it gives you the calculation of the fluids what is required for the resuscitation.
So the transfer criteria of children to specialized burn unit include burn more than 5% total body surface area, any burn involving the face, hands, feet, perineum, or the joints, circumferential burns, burns associated with inhalational injuries, electrical and chemical burns. So would you like to add something?
In addition to these burns, I think the burns where you have to suspect there is some child abuse is there, and you can think or you can have suspicion of the foul play, or the children who have the associated injuries due to the other injuries. For example, a child has a fall, he has the head injury, abdominal injury, or the fractures, or the wounds and the burns which are not healing for a long time, maybe 2 to 3 weeks. Such children should also be sent to the specialist burn units. And it is said that all the full thickness burns in children should actually be treated by a burn center, burn specialist center. These are some of the additions in addition to this.
So burns sustained in an enclosed area. These lead to smoke inhalation, airway injury, which is compounded by soot, inhalation of noxious substances, and hypoxia of the patient. There is significant airway edema where early tracheal intubation is mandatory in severe cases. So, how do you deal in these patients of airway injury?
If we suspect an ARV first off or suspicion of the inhalation injury, mainly it is a suspicion. If you have the burns which are above the neck, involvement of the face, or there are the signs of the inhalation, like there is edema of the lips, there is soot in the oral cavity, or singed hair are there, or the hair on the face are singed, and there is stridor is present, and there is gross edema. So suspicion should be that airway injury is there, that the inhalation burn is there. So you immediately give them the humidified 100% oxygen. If you have a suspicion of the carboxy hemoglobin monoxide poisoning, then 100% oxygen is to be given. And there should be a very low threshold for the intubation. So, because the airway of the children is very narrow and it gets collapsed by or get obstructed by very little edema. If you start a resuscitation, it gets closed. So intubation, you should be very prompt in intubating such patients, because then it will be very difficult for you to intubate the patient. Even if you take the help of other things, video fluoroscopy and all that, you will not be able. And after you have intubated, you can do the bronchoscopy, which may not be available in every center, for the actual diagnosis of the inhalation injury.
So, what is the average length of stay of these patients, and when do you convert to tracheostomy in these patients?
Actually, these patients we have seen, if inhalation injury in the child is there, about intubation is usually for 7 to 10 days, maybe a week or so. So you can safely extubate the children. And prolonged is when it is beyond 2 to 3 weeks. And I have seen in my practice very less people will convert in the tracheostomy. Very less people, children. So most of the children come out. But if the need is there for the better control, there is no doubt that tracheostomy should be done if it is needed. I can say beyond 10 to 14 days, you can go for the tracheostomy in a child.
So, the box score, it is used to determine the mortality in burn patients. Here, the age and the percentage of total body surface area is done. And the total score of 100 would represent a predicted mortality of 100%. But as we have progressed to good clinical care, so some large scale studies suggest that about 100% predicted mortality is at a score closer to 160 rather than 100. A modified box score is available where the inhalational injury is present. 17% is added in these patients to the final score. So, what is your experience with the box score?
Box score, or especially the modified box score, is a very good score for the prognostication of the burns. It can help us in the prognostication, like what is the severity of the burns. You can teach your residents about the severity, it is one of the severity scores, and it is very helpful in counseling of the attendants of the patient as well as the parents. Pediatric ones we are talking about the parents of the patient, that the severity is such that the score is coming near the 100. So the mortality is nearing the 100, so it can prognosticate also, and it can counsel the patients also, that we are doing our job, we are trying our best, but whatever knowledge, whatever we are seeing, our score is high, so the condition is sick. So it helps in counseling also, and also teaches us about the severity of the burn. And it has really a value in its own place.
Moving on to fluid resuscitation, which is a key element in burn. For minor burns, oral rehydration is enough. Formal fluid resuscitation is started once the total body surface area is more than 10%. Parkland formula and modified Brooks formula we have been using. What is the fluid of your choice in resuscitation, and which formula do you prefer?
Actually, we also go by the same formula as this, but we are using now the modified formula. And what we have been taught previously, that there are special formulas for the children, because in the children you have to give the fluid for the burn, as well as very importantly you have to give the maintenance fluid. So we had special formulas for the pediatric resuscitation, called by the names like Cincinnati formula was there, Galveston was there. These are based on the percentage of burns. Like the you give the same 4 ml per kg per percentage of the burn. Then you give the maintenance fluid. You give the maintenance fluid of 1500 ml per meter square for the maintenance of the child. So similarly was the Galveston formula. It was also based on the same. And very important resuscitation in children that the glycogen stores are very less. So you have to give some source of the glucose or dextrose to the patients, to the child. So hypoglycemia should not be there. That is very important. Rest we follow the same formula, and very important in resuscitation in everybody, including the children, is that urine output. So you have to monitor the urine output. In infants, usually we keep it to 1 to 1.5 ml per hour per kg per hour, and maybe the older children you keep it to 1 or a little bit more than 1. So urine output will tell whether your resuscitation is adequate or not.
The fluid creep. Once over resuscitation is there, then fluid creep occurs. It can lead to ARDS, multi organ dysfunction, abdominal and limb compartment syndrome, and cerebral edema as well. So, how would you suspect an abdominal compartment syndrome and how would you approach it?
Abdominal compartment syndrome is a very serious problem. Especially it's a part of what we used to say that the fluid creep. What happens that which you should suspect when there is the gradual increase in the abdominal girth, abdominal becoming more and more distended, it is becoming tense. There is the embarrassment of the ventilation or respiration is there, and very importantly, urine output is decreasing. Plus, you have an objective assessment of your resuscitation that you have over resuscitated. Because previously, what was the game that as much fluid you can give, you go on giving. But this is not the truth. Your fluid resuscitation has to be within some limit. So over resuscitation plus the urine output is less because of the pressure. So embarrassment of the respiration and tense abdomen. These are the features. And it is to be dealt with very promptly. You have to sedate the patient. Anti-cholinergic, anti-muscarinic drugs are to be given. Then, if needed, and the cause, what is the cause? So you have to prevent that cause, which is because burn is not only the cause. We are describing the burns here. Secondly, if there is no option, then you have to go for the laparotomy and opening of the abdomen. That will relieve it. And to diagnose it, you have to see the urinary ability pressures. Usually, the abdominal compartment, when the pressures are more than 20 mmHg, which we usually take, if you go by the measurement of the manometer measurement of the pressures.
So, moving on to airway, it is particularly important in facial and inhalational injuries. Airway edema occurs, especially in the first 48 hours, and it should not be underestimated. The use of video laryngoscopy in such cases has become a common practice. Sir, when would you go for an early intubation in case of a conscious and a well-oriented person?
If a patient is conscious and well oriented, actually there should be specific features in that patient which will prompt me to go for intubation. First of all, what I already said that if there are the features of the inhalation burn, for example, there are the burns of the face is there, burn of the neck is there. There may be other telltale signs of the inhalation. There is stridor. Then always there should be a low threshold for the. You can do bronchoscopy of the patient to see for that, but there should be very low threshold for the intubation because intubation can save the patient. So if a patient is at the beginning is well oriented, he is conscious. But it should prompt you that in a fraction of the time he can go because the airway is very small and it can you can lose the airway and you can lose this golden time to intubate the patient. Whenever you have a suspicion, you go for it. There is nothing to lose. You can gain, but you cannot lose with the intubation anything.
Temperature control is very vital. Burns compromise the integrity of the skin, leading to significant heat loss. There is constant measurement of core temperature, and it is essential in the operation theater as well, which is commonly done by rectal, esophageal, or bladder temperature probes. Trained and dedicated staff are very, very crucial in our pediatric ICUs. The same staff should continue to oversee these patients in our theater as well. High frequency oscillation ventilation is used respiratory failure when conventional ventilation has not been successful. In such cases, if it was deemed absolutely necessary for patients to go for the theater, then reverting back to conventional ventilation using the anesthetic machine is likely to worsen their condition. Such patients often have ARDS, and meticulous care needs to be taken with their respiratory function. Burned wounds are typically sterile. The initial period, there is colonization of the gram positive in the first 48 hours and gram negative within a week. Though colonization does not necessarily indicate infection, sir, I would like to ask you what are your criteria to start the antibiotics and what investigations do you go for these patients?
So when a such patient comes as a burn comes to us, we don't start an antibiotic as the outset. For because burn as such is as you were saying, it's a typically a sterile wound. So within for about 5 to 7 days, we don't give any antibiotics. And if the patient becomes febrile during this period, if you don't have any report, microbiological report with you, we start with the broad spectrum antibiotics. Then we narrow down as the report becomes available to us. So routine is with us is that. Then secondly, what investigations we do? We do the baseline investigation already that the CBC is done, hemogram, then the KFT, LFT, all that is done. So especially what markers we do in the burns, that is important, especially to rule out the sepsis. First of all, we use the trends of the TLC, total leukocyte count. We see for the trends of those, whether it is decreasing or increasing. Secondly, the CRP we use very routinely and procalcitonin. And very important, which has recently come, is the ratio of the neutrophils to the lymphocytes. It can lead to you whether the sepsis is in setting or not. So all these, if you take together as a wholesome, they can dictate you whether sepsis is there or the patient is not infection, that there is no sign of the infection. And they can also dictate whether sepsis is procalcitonin especially. It is a role, it can, when the antibiotics are started, it can tell you that when to stop the antibiotics. Because if it has come down, it can show that there is no sepsis and now the antibiotics are not required and you can de-escalate them.
So, you have to exclude other sources of infection like the respiratory or urinary tract, and antibiotics should be continued during the perioperative phase. So, I would like to ask when do you suspect fungal sepsis and what are the antifungals of choice at your center?
I would say tell you that unfortunate for us that with the rampant use of antibiotics, secondary infections are ensuing in the burns. And one of them very notorious is the fungal infections. And there are no specific signs and symptoms for these fungal infections. You only have a suspicion when you see a child who is continuously febrile, but he is on a good antibiotics. Maybe the antibiotics which the report or microbiology report based on microbiology report is there, but he continues to be the febrile. Wounds continue to be on the bad side. They are worsening. So you suspect the fungal infection. And maybe there are fifth signs are there. There may be that dark hemorrhagic areas may be there. There may be black spots in the wound. And characteristically, what we see that due to the saponification of the fat, there occurs what is called a cheesy yellowish appearance in the wounds. But these are all the suspicion, and there are no specific signs as the bacterial infection you have. Then, regarding the start of the antifungals, usually if the child is hemodynamic, if the patient is hemodynamically stable, so we start with the fluconazole. But if the patient is not hemodynamically stable, we go for the casofungin or the amphotericin B. And amphotericin B, as you know, is very toxic. There are a lot of side effects. So we can go for the what is the liposomal form of amphotericin B or the casofungin in the sick patients. But if the patient is somewhat, you can say, stable, we can go for the fluconazole. Azoles have a good effect.
So, moving on to acute renal failure. Many of these children land up in renal failure with severe metabolic acidosis, fluid overload, and electrolyte imbalance. They may require continuous renal replacement therapy in a child, in our children. So, moving on to the pain, the causes of the pain can be due to the background pain due to extensive raw area, breakthrough pain. Despite of administering the medication, still the pain is there in between. Procedural pain. There are many things which we do to the patient, like the dressings, the change of position during physiotherapies and all. So these also cause some pain. And the post-operative pain, you all know. Post-operative pain is managed with the help of simple analgesics and opioids. Regular paracetamol and morphine are required and are commonly prescribed. So I would like to know, is morphine prescribed at your center? And if yes, in what dosage?
Yes, morphine is being prescribed in our center. We usually start with the paracetamol and we usually resort to the morphine in the ICU. When we have the patient in the ICU, we give the morphine there. Usually, we give in the dose of the 0.05 to zero point 0.1 milligram per kg, and we can repeat it 6 hourly as or as needed. So, in the ICU settings, we give the morphine. Rest, if the patient is in the our burn ward only, we usually start with the paracetamol. Then we can give the add-on multi-pronged anti analgesics as the need arises. Plus, very important, the children is the other therapies. As you were telling, there are the play therapy. There can be distractions. Therapy can be there. So, or the you can see the lullaby given by the mother, rocking or the stroking of the bed. These also help. Guided imagery. These are the procedures which can help in the children, especially during the dressings. And during the dressings, you can give ketamine, as you can give ketamine also. And there are other newer analysis coming up, which are more safer, especially in the children, and which have a good effect in the various forms of the pains, because there are multiple pains which are you see in the patients. There is not only a single pain, there are multiple pains. You have the pain during the dressing, you changes, you have the pain which is the background always, you have during the procedures, post-operative pain. So there are the different guidelines and the different protocols in all the centers to manage these types of pains.
So oral morphine or IV through continuous or PCA pumps can be used. Those who are intolerant to morphine can be given oxycodone, and it is preferable for renal failure patients and has a superior bioavailability. NSAIDs should be used with caution. For procedural sedation, it is required during dressing changes, staple removals, showers, and a multimodal approach, like Sir has told, like the guided imagery and play therapy, are administered for pain control. The background in procedural pain are commonly dealt with the use of ketamine, propofol, benzodiazepines, and opioids. Dexmed is nowadays used both for procedural sedation as a sedative in pediatric ICUs, and it has an analgesia, sedation, and has rapid onset and offset. So it provides sedation paralleling natural sleep. There's a huge psychological impact due to this pain, due to the acute and background pain, due to the multiple procedures involved, and due to the physical changes which occur in pediatric age group due to birth. So the key takeaways from this article are early resuscitation, pain control, and airway care are life-saving. Anesthetists do play a central role at every stage with new tools enhancing safety and precision. Optimizing procedural sedation and analgesia in a child will help reduce the anxiety. Thank you
Dr.
so
Harsh,
much.
can I add a few points? Can
Sure,
I add
sir.
a few points?
Sure, sir.
One thing very important in pediatric burns is that it is said that these pediatric children, they are not the small adults. Never treat them as small adults. So
Right,
the adults you give the 500 and you give 215 children. No, they are
right,
not small adults.
right,
They have different physiological basis. Actually, what I was saying, their glycogen stores are less. Their kidneys are not mature enough, so they cannot deal with the electrolytes and other things. So that the if the renal function is not appropriate, so the glycogen stores are not there. So their physiology airway is very small. They go into the hypothermia very quickly. They cannot come out of that. So all these points add to the physiology is different. So physiology is not same as the adults. So we have to teach the pediatrics as a pediatric different, not at small adults. And there are different guidelines for everything, from the estimation of the burns to the resuscitation to the pain management to the wound management and the psychological. Psychological is very important because the child has he's anxious, he's always pain, there is always pain, and especially when the raw areas are uncovered, the pain endings are getting. So one of the ways of reducing the pain is to cover the wound. Secondly, parents are also very anxious. They have a feeling of guilt is there, they are anxious, they are very actually they put everything on them that it is our fault. They have a feeling of guilt in them that the burn has caused because of us. So in children, all these have to be kept in mind, and you have to treat a patient and the pediatric child burn in a holistic manner, not as a small adult. That is the one thing which I want to convey.
So, point well taken, sir. So, with this, we would end our podcast. Thank you so much, sir, for giving your valuable time.
It is my pleasure. I thoroughly enjoyed whole of this podcast, and I learned many things from this podcast, from your presentation. Thanks a lot from me also. And I should thank you, Dr. Harsh, as well as our Nabi, as well as our the an organizer of this podcast, Dr. Raj Manas, for giving us this opportunity. Thanks a lot.
Thank you, sir. So, we'll stop our presentation now. Thank you.
Thank you.